Good evening and welcome everybody. My name is Alec. I'm the Managing Director for Wound Care People. Welcome to this evening's Facebook Live, which is Don't Let Hard to Heal Wounds Hold You Back. Tonight's speakers are Jacqui Hughes, who is a Senior Healthcare Outcomes Manager at Smith+Nephew, and also Jeanette Milne, who's the Chief Matron Community, Northumbria Healthcare NHS Foundation Trust. I almost didn't get that out, Jeanette. This evening session is brought to you in partnership with Smith+Nephew. So I'd first and foremost like to thank Smith+Nephew for supporting this event. We're very pleased to be working with them again on these wonderful Facebook Live events. As always, certificates for your CPD for revalidation purposes will be available at the end. Bear with us if we've got any technical issues. You'll see that we're actually working from home as we have done since the start of the pandemic. I think that's probably it for me, other than to tell you, please do ask as many questions as you can throughout the event, because the more you ask, the better it is, because I'll be coming back after the presentation with a live Q&A. I'm just going to do a quick check to make sure that Jeanette and Jacqui are actually with me. Jeanette, Jacqui, are you there? Can you hear me?
We're here, Alec.
We're here.
Yeah, and are you both well?
Both well.
We're very well, thank you.
Excellent. Well, in which case, without further ado, I'm going to hand over to you both. Thank you very much, everyone, for joining us again. It's a lovely evening, and we do really appreciate your time. Hope you enjoy the presentation. Jacqui, Jeanette, good luck. I'll see you at the end to come back for the live Q&A.
Thank you, Alec, and welcome to the first part of this Facebook Live session this evening, which looks at terminology in wound care, and whether it's a good time for a review of the words we use to define a wound that is not healing. As we go through the presentation this evening, I would ask that you reflect on your own clinical practice and look at whether the potential issues that might arise as a result of a lack of consistency in terminology have ever been experienced by either yourself or your colleagues. The issue remains that the challenge of hard to heal wounds is as evident today as it's ever been. I think everybody here tonight will be familiar with Julian Guest's work on the prevalence of wounds, and what this shows is that there does not appear to be any decrease in the sheer number of wounds that we are struggling to heal on a day-to-day basis in the community. And this burden on community services is not likely to be sustainable in the long term. This is despite new technologies and a real focus on wound assessment and early intervention. In fact, the data appears to suggest that hard to heal wounds could be being treated in the same way as any other wound. And Jeanette will be covering in more detail in the second half of tonight's session on the potential solutions for hard to heal wounds, focusing on what can be done given the limited time and resources that are often the reality of community nursing. If we want to strive for excellence, and when we think of, for example, the NHS triple aims of better outcomes, better experiences for patients, and better use of resources, then we need to look at clinical practice and really focus on reducing clinical variations in both the assessment and the treatment of hard to heal wounds. That then poses the question for this evening's presentation on whether the different terminology for defining a wound that is not healing could potentially hinder the drive to reduce variations in clinical practice that we seek to achieve. So does the number of words we use for a wound that is not healing make the assessment and treatment of wounds more problematic than it should be? So does language matter? Well, if you read any of the healthcare resources associated with chronic conditions, then the focus on the language we use with other HCPs and the patient is very evident, and rightly so. In fact, I would really encourage everyone tonight to have a look at the NHS Diabetes resource called Language Matters, which talks about language in terms of patient care and how that can affect clinical outcomes. Samantha Holloway, academic editor at Wounds UK, has also written a piece recently on the language of non-healing wounds. Understanding the power of words and how they influence behaviour can help us to ensure positive health outcomes for all our patients. But does language matter in wound care? For the patient, most definitely. So the use of positive language can build confidence. It can lower a patient's anxiety. It can improve self-care, whilst poor language can stigmatize, be hurtful, and often quite detrimental to good clinical outcomes. And what about for the clinician? Well, if clinicians are potentially confused about the different words we use for a wound that is not healing, could that potentially change the way that the clinician thinks about a wound? Take the word chronic, for example. For most of us, that usually means there is an assumption that having something chronic for a long time is almost expected. But think about a chronic wound. What does that mean to you? What does that mean to me? What does that mean to Jeanette? I think the same definition might not resonate with everyone tonight. So we might already have a different view on what a chronic wound is. So already you can see that we have a potential for confusion. Then if we think of the patient, being told that you have a chronic wound could be distressing, especially if they're thinking in terms of other chronic conditions that they've either got themselves or maybe they've read about. Now I want us to think about how does that potentially change the way we treat the wound? Are we as rigorous with changing treatments when the wound is not responding when it's chronic? Are we reassessing often enough? Does managing a wound rather than treating it become the norm for these patients? And does this attach a stigma to the patient with a wound? Remember that stigma in any shape or form, no matter how small, can influence the perceptions of healthcare professionals. So how does that then make the patient feel? What we don't want is a patient that becomes disengaged with their care due to a wound that is not healing. If we want to, as clinicians, promote concepts such as self or shared care, for example, then the choice of words, so that choice of terminology, really matters. If we are not clear in our minds about what a non-healing wound is and how to treat it, how can we expect a patient to understand enough to self-care for themselves, for example? And I just want us all to remember tonight that the choice of words we use has enormous power, which can have positive or negative effects, and that some words and descriptions are potentially problematic for both clinical practice and the patient. So it seems timely then that we review the use of common terminology in wound care, particularly for those wounds that are struggling to heal. So just a small refresh now on why we use terminology in healthcare. The primary reason for using medical terminology is so that those involved in healthcare have a common, consistent language. It's very specific, so more than one clinician in theory should be able to treat the same patient in exactly the same way with exactly the same outcomes. So using terminology should, if it's used appropriately, eliminate misunderstanding and vagueness. However, when we look at the words we use in wound care to describe a wound that is not healing, then this might create the very thing we are trying to eliminate, that misunderstanding and vagueness. When we looked to the research to try and help us, Cure et al. In 2017 found that there were only a few studies on chronic wounds had been included in systematic reviews. And this was because what they call the great disparity in the terminology and definitions of a chronic wound. We're not covering definitions this evening, of course, but when you think of the discussions around the duration of a wound, for example, and its relation to that wound being deemed as hard to heal, there's lots of documented evidence, all with different criteria, trying to help us to make a clinical decision. So when should the wound be judged to be non-healing? Should it be at 3 months? Should it be when it's not reducing in size by 20 to 40% after 2 to 4 weeks? Or when there's not complete healing after 6 weeks? With this many variables to consider, there can be no doubt that this can be confusing to clinicians delivering wound care. On this slide, you can see a variety of words used to describe a wound that isn't healing. Chronic, stuck, stalled, unhealing, static, hard to heal, non-healing. I don't know about you, but I'm totally confused by all these words, and who wouldn't be? Lots of different words. The problem here is that we're using different words that should mean the same thing, but each term potentially has its own definition, or at least a clinician's own interpretation of that word. So how can they mean the same thing to every clinician? If we could decide which term accurately reflects a hard-to-heal wound, then maybe, just maybe, we would be in a better place to reduce some of the variations in clinical practice that we know exist. Of course, I'm not suggesting that simply changing the terms we use will change the outcomes of hard-to-heal wounds on their own. And of course, there will be some wounds that we know will not go on to heal for a variety of reasons, and some that are simply being managed with the ultimate aim of comfort, for example, those palliative care patients. But with a rigorous wound assessment, effective management of patient comorbidities, and appropriate timely treatment interventions, then we do have the opportunity to change the future course of an ever-increasing wound population. And above all, just understanding, addressing, and managing the challenges of hard-to-heal wounds can lead to better clinical outcomes, improved patient quality of life, and reduced overall healthcare costs. I would now like to share with you some of the top-line results from a clinician-focused survey that asked questions about terms used in wound care and whether the respondents thought that having too much terminology for a hard-to-heal wound could potentially affect the assessment and treatment of wounds. We invited clinicians to participate from January to March of this year, so it's a new survey. We had 150 respondents in total from a variety of clinical backgrounds. We had community nurses, TVNs, acute nurses, podiatrists, practice nurses, etc. And our aim was to start to learn about how clinicians use terminology in clinical practice and whether any terms resonate more than others. And as with any audit baseline, it was really important to understand what is currently happening, so what the potential issues are, and in essence, what does practice look like now? When asked whether having different terminology impacts on assessment, that is, does it make things difficult or challenging to understand, 87 out of the 49 who responded for this question said yes, it did, while 50 respondents said that it didn't, and 12 said that they simply didn't know. Split data demonstrated that a large proportion of the 50 who said no were either TVNs or classed themselves as a wound care specialist, while the 87 who said yes were predominantly community nurses. So over half of the respondents felt that having different terminology made the assessment process more difficult or challenging to understand. So going back to the first part of the presentation, think about those questions that we first sort of posed, and how can this potentially affect how wounds are treated? We then asked what terminology the clinician would prefer to use for a wound that is not healing according to plan. You can see on the slide that over a third of respondents said they would prefer non-healing, followed by hard to heal, and then chronic. Those in the other category were complex, stuck, and static. So it might be, therefore, we still have all these words, this terminology that we use, a real opportune time to try and understand what drives this choice of terminology. But more importantly, how being consistent with the terms we use in clinical practice might drive a change in perception and potentially improve outcomes. Finally, clinicians were asked to state their reason for the choice of terminology. By far, the largest response was easy to understand for all health and social care professionals. Remember, in a previous slide, we said that the primary reason for using medical terminology is so that those involved in healthcare have a common, consistent language. It's very specific, so more than one clinician in theory should be able to treat the same patient in the same way. And that using terminology should, if used appropriately, eliminate that misunderstanding and that vagueness. So what does this potentially mean for clinical practice? So think back to some of the issues we've looked at tonight. Do any of the questions posed ring true for you? We asked the question earlier, does the different terminology for defining the wound that is not healing potentially hinder the drive to reduce variations in clinical practice? How do you feel about this yourself as a clinician? Will this prompt you to think about this on a personal level or in your teams and start to clarify the terminology you use around hard to heal wounds? We then looked at thinking about how does the use of terminology potentially change the way we treat the wound? Are we rigorous with changing treatments when the wound is not responding, when it's hard to heal, for example? Are we reassessing those hard to heal wounds often enough? Are we simply managing and not treating those wounds? Are we treating all wounds the same, despite there being clear signs of a wound that is not healing? And how much does all this attach a stigma to the patient with a wound? Adopting simple terminology that means the same to all clinicians could potentially be beneficial in terms of identification and subsequent treatment of a wound that is not healing. Our survey was limited, and it was intended to be a starting point for a wider discussion. Therefore, further data is needed on the potential confusion in terminology and how that relates to wound care practice. I really feel tonight that we should be striving as a wound care community to look at the consensus in terminology that we use for wounds that are struggling to heal. Thank you for your time tonight, and I will now hand you over to Jeanette for the second part of the presentation for this evening. Thanks, Jeanette.
Thanks, Jacqui. I think for me that sums up some of the confusions that we have in wound care around how we talk to patients, the terminology that we use to describe things. And I think we have a real call to action, and Jacqui linked that very beautifully to the data that we have from Julie and Guest. But we know that there are lots of constraints to why we don't act. So the time element of community nursing, that constant pull between planned and unplanned care, the resources that we have available, so be that from a journal perspective or even from the digital system that you use and our digital ability to record wound metrics in a way that the system works for the people. And I think knowledge and skills are and have been immeasurably impacted by the pandemic. There hasn't been as much industry involved education other than online, but the lunch and learn meetings that our district nurses used to thrive from have very much been missing during the pandemic, and our staff turnover has been immense. And that confusion, not just in what you refer to a wound, can be compounded when the patient gets multiple different caregivers going in every day. We know that wound care costs £8.3 billion per annum, and that really should focus our minds. But we know from a community perspective that our community practitioners that are out there, out with our specialist teams that focus on things like tissue viability, podiatry, that focus on the diabetic foot wounds per se, they are specialist generalists. And they deal with end of life, they deal with diabetes, injections, various different things are being challenged and managed on a day-to-day basis. From my experience, what patients want is they generally want that wound to be healed. So I think it's really important that the language we use resonates with patients, as Jacqui said, not just with caregivers. And I absolutely acknowledge that not all patients will have a wound that heals, and that we need to have an open and honest dialogue with our patients and enter into a partnership agreement where we are open, honest and realistic about what the potential outcomes can be. But generally patients perhaps talk about the things associated with the wound, that it is painful and they would like the goal of care to be to reduce that pain, or they would like reduced leakage, because exudate can lead to smell and odour, and smell and odour can have a confidence impact, and it makes patients isolated and they feel unable to perhaps get on with their lives. If we haven't had a wound ourselves, it's very hard to understand the impact of a wound on a patient's life, but it's very important to listen to that impact and make sure that any solution that you are offering the patient ticks at least a few of their pronounced goals of care. In terms of making the case for negative pressure, I think it's really important to think about the outcomes that the patient wants. So this is a young woman who's undergone a laparotomy and laparoscopic resection of gallbladder. The wounds have broken down and the exudate is high. There is quite a lot of pain there, but you can see this first image on day 1 taken, and then just 3 days later, that kind of change in the impact. And I know that, you know, the nurses amongst you definitely didn't come into nursing to be best wound photographers. And there is something about the depth away from the camera in these images. But you can see there that image on day 3 looks completely different to the image on day 1. And that has just allowed the exudate to be managed, allowed that person to get on with their lives in a confident way. I think the other thing about making the case for negative pressure wound therapy, be it single-use negative pressure wound therapy that as was used with the previous patient, is the amount of data that is out there to support this therapy. And it is at all different levels. As you can see on the slide here, there are a number of randomized control trials, meta-analysis, case studies, case cohorts, and I would say that it's one of the things that over my 25-year career in the field of wound care has very much changed my practice. We have medtech guidance from NICE, and I have spent an awful lot of my career investigating this medium because it can change the lives of patients. It can have such a positive impact on patients. Patients can self-care, and it's important that we're able to reflect those outcomes to our patients and make them informed so they can make an informed decision about the care for them. And it's really a myth in wound care that the cost of a product equals the cost of a patient outcome. We know from an economic perspective, 67% of expenditure is spent on 30% of wounds. So those non-healing or hard to heal wounds that we see, but we have a responsibility to act. We have huge amounts of variance across the country in terms of staff vacancies. And as Jacqui pointed out, we have variance in the care that we deliver. And one of my call outs to you this evening would be a lot of nurses, podiatrists, and generally medics across the NHS portfolio would really not necessarily choose the treatment that they're offering to a patient. They might choose a different treatment for themselves. And I think a treatment that reduces staff time and the frequency of dressing changes, but improves outcomes and can impact on patient satisfaction whilst preventing some of these hard to heal wounds needs to be considered. And it needs to be considered more on the basis of the overall cost than just the cost of the dressing per se. In that previous patient, the dressings were being changed every day. They were coming to a clinic to have those redressed every day. The single-use negative pressure was applied, and that patient then was brought back at day 3, and then a dressing applied for 7 days, and then the treatment was discontinued and the patient went to self-care. What we know about what patients say and see, and some of the things that patients say and see or have said to me over the years, is that every nurse did something or used something different on my wound, and very few staff explain why. And I think we need to get away from the fact that wound care can sometimes be something that's very transactional, where you know, task focused, because of the number of visits our community staff are making. I'm not apportioning any blame in this, but we can sometimes be compelled almost to dash in, change the dressing and come away without that reassessment and that call to action. And often it's very easy to blame the inanimacy of a dressing, as opposed to saying, actually, I need to stop. I need to think about what we're doing here. I need to reassess this. I need to go back to the clinical record and make sure that things are progressing. I need to listen to the patient, because the patient is the one constant in that. And it's really important that we focus on the right thing to do. We might, for example, depending on the context, choose to drink water. We all know water is good for us, but in a social context, a glass of wine, from the evidence, would also suggest that that is good for us too. And we've all missed some of that social interaction during COVID, that face-to-face meeting, the training that is done that's very practical and that is not on Teams. But we know that perhaps wine costs more than water, but sometimes it's the right thing to do, to choose differently for our patients. And the impact of choosing differently has huge opportunities. And I think in terms of those opportunities, we need to think about reducing the overall burden, the burden on staff time, on patient time, in simplifying care to reduce the hangover of those patients, to prevent chronicity, as Jacqui said, or to prevent the hard to heal wound, to look to the self-care options, but really to push the boundaries in self-care and to really ensure, and I think this is one of the key things that self-care has to offer. It offers that consistency and continuity of care, because if we're not all seeing all of the patients, and the patient is that one constant and they're able to do that, and I'm not saying every patient is, and we can tie them into red flags and clinics with video consultation and provide that headspace for them, then they can be that consistent caregiver and that one constant within their journey. We also have an opportunity to think about pathways in care and simplifying decisions for our caregivers. And we need to avoid more expensive treatments being only in the armoury of the more experienced clinicians. We need negative pressure wound therapy to be available at the point of care. We need clinicians to be confident to use it. And a pathway to simplify decisions that's embedded into the clinical record, or even better if it can be embedded from a digital perspective, that is taking people through some decision making that looks at not just what the wound is looking like, but the patient acceptability criteria and the patient's ability to manage such a system, and also looking at the red flags for something can avoid some complications in practice. And I just wanted to share a case study with you of somebody that we unfortunately looked after. So we have a 54-year-old lady who had initial surgery for a hysterectomy. During that hysterectomy, there were complications that came about sort of post-operatively, where she had a perforated bowel and she ended up undergoing a second laparotomy. That lady was overweight from a BMI perspective, and whilst it was an elective gynae operation at first, those complications meant that she ended up with a secondary operation and free fluid in a peritoneal cavity, which then led to us triggering one of our post-operative high-risk surgeon incisions pathway, which was to instigate single-use negative pressure. Unfortunately, even though that pathway says that we should continue that treatment for 7 to 14 days, that was removed at 3 days and not replaced by staff in one of our units. And unfortunately, that lady's wound then went on to separate at the top and bottom of that incision. The image that you can see here on the screen is when that wound had been opened fully. But unfortunately, during that packing experience of the wound being packed, the staff were focusing on what was being put into the incision, and it was only open at the top and the bottom with a skin bridge in the middle. And that packing, was numerous that was going in. And unfortunately, one of the pieces of material got left behind. So we were almost trying to wallpaper our stairs through the letterbox here and using plastic probes to probe the depth and measure the wound, and the nurses were really great at that. But because they weren't using a gloved finger and they couldn't see, a piece of retained hydrofiber dressing got left behind, and that delayed healing for this patient and led to a third operation. So we've very much got consequences there for this patient in terms of odour, smell, exudate, numerous visits. And if we had only stopped and thought, when the wound broke down and got this patient assessed and put negative pressure on, albeit perhaps not single-use negative pressure, but with a gauze-based negative pressure with a single piece being inserted into this wound, we could have avoided some of the complications for these patients. And I think sometimes initiating a change in practice can be really stressful for clinicians. But it is a time for change, and we need to consider our patients at the heart of what we do. Jacqui quite eloquently talked about the NHS aims, better aims, better experience and better outcomes for our patients. And this case study here looks again at another laparotomy patient, perhaps something that we wouldn't necessarily consider single-use negative pressure for. But this was a 21-year-old that had undergone this for an emergency appendectomy. And you can see the images here that were being sent through to our day assessment post-operative treatment unit. And you can see some bruising around the umbilicus. So whilst this patient is young and previously, fit and well, there was already a risk to this incision because it was what we would call contaminated surgery. There was a lot of bruising around that umbilical wound and potential for this to go horribly wrong for this young lady who wanted to get back to work. That was her key aim, to get back to work. But she was young, she was agile, she was able to take on self-care. So what we did was initiate single-use negative pressure with her, and you can see the progression that the wound makes following that. And she was able to, after only a week's worth of therapy and changing that dressing herself after 3 days, get back to work with no dressings in situ. And we prevented that wound by using the attributes of single-use negative pressure wound therapy to lift the skin, to drain some of that lymph fluid, the edema around the wound, and to really sort of kickstart healing in something that was potentially going to go down a very different route where she would have needed dressings more frequently. And yes, she could have cared for those, but her main aim was to get back to work as quickly as possible. We need to really challenge the inertia in practice and think about what we do differently. And it's really difficult, and I'm not saying that it's easy, but we can all do this. It's really important to try and focus on the change process, focus on how we move through that change. And whilst it can appear scary, it is about thinking about where we want to be, think about the end in mind, think about the goal that we have for our patients and simplifying that journey for all of our colleagues. That's about the language we use, about the therapies we use, about being available at the point of care and the point of access. Because if your trust per se doesn't allow you to use single-use negative pressure therapy or doesn't allow you to use negative pressure wound therapy, then that's the change in practice. Getting it to the front line and getting them trained in its use might be something that you want to consider. We can't hold expensive therapies for just patients that fail to heal. We need to see the red flags and we need to act quickly and in the right way and in the way that we would want to be managed ourselves. So we are seeking to heal that wound. We need to think about what is good, what is better, and what is best, and how we monitor that, and really encouraging people to be the best that you can be. You can see two things on this slide that perhaps make very little sense to you. You might have all seen run charts. The NHS is awash with run charts and looking at the different interventions you do to see what makes the biggest impact on patient outcomes. But what I wanted to point out here was a real sort of moment of clarity in a session that I attended by a speaker called Steve Heads. And he just talked about looking for your glimmers of brilliance. Now that might be about succession planning and seeing who is going to be the next leader within your teams. It may be about somebody who's got that fire in the belly from a wound perspective that loves to make a difference to patients. Look out for those glimmers of brilliance in your staff and give them the autonomy to act. Give them the ability and the tools and the support and that inclusive leadership to see them succeed, and water them almost as if you're watering and nurturing a plant. Because if we nurture our staff, we can do better, we can be better, and we can be best. The other thing that Steve talks about is this 149 effect. And I think the 149 effect, it just reminds me to talk about, don't be afraid in that change cycle while you're being, good, better and best, to challenge yourself, to think that you don't always get it right. And we might go up a bit of a dead end, but it's all right. We dust ourselves off, we come back stronger, we learn from that experience and we continue. Any inventor out there didn't necessarily see that as a failure. They saw that as the lesson and they moved on. And I think in wound care, Jacqui mentioned earlier about that 40% reduction in wound volume as a prognostic indicator. You'll see when I was talking about simplifying decisions, that's in the pathway. It's asking staff to really think about that as that prognostic indicator, thinking about that large and long time a wound has been open. It's much less likely, to heal. And it's important that we ultimately have the goal to heal wounds as quickly as possible, acknowledging that palliating the symptoms in some patients is absolutely something that we will need to do, and it's absolutely appropriate for some patients. But we need to simplify both the narrative in the way we speak about wounds and the products when they're available, and not always think about the cost of the product, because it is not equal to the cost of that patient's treatment. The biggest cost in wound care is the cost of your time. So we need to collect that data, and that data can be used to convince nurse managers, convince your colleagues that they need to also make this change in their practice. And I would encourage you all to think about, just do it and beg forgiveness if you don't have the pathways, and collect the data and use this data to convince people to do things differently. We've talked a lot about reasons why tonight, and I think Jacqui talked about the way we discuss things with patients, what that means to healthcare professionals, and we need to improve outcomes for our patients. We need to do that for a number of different reasons. Staff satisfaction. I fundamentally believe nobody comes to work to do a bad job. It's systems that beat people, and we have to get better systems. The National Wound Care Strategy is championing the role of different elements of that. Simple pathways, looking at different ways of documenting wounds, that call to action. A good system would truly be able to tell us that the wound is this size, and that's equals this in volume, and on a regression analysis, that wound hasn't met that criteria and it flags to clinicians. You know, for me, that shouldn't be a utopia in 2022. We need to think about reducing costs, but when we think about costs, it's not just the visible cost of the dressing on the formulary, it's the overall cost, that cost and stressed staff when they're seeing multiple patients and doing multiple visits, when if we could just change up what we do and how we do it, we could change some of that narrative, a bit like getting patients into compression with, you know, that don't have any red flags at week 2, as opposed to waiting for that wound to become chronic or non-healing. We need to think about the organisational benefits of that as well, that increased productivity and freeing time to care on other things that enable us to be that health service, to focus on that proactive care and rehabilitation and reablement services to help people regain their strength and return to the workforce, especially in some of the younger patients that I've talked about this evening. Now, I know they're not the lion's share of the wound patients that we manage. However, in healing our patients and empowering patients to have the best treatment possible is the way we will close wounds. And I would, you know, go back to my earlier point about a call to action, that having an open mind, and that's probably one of the reasons that you're here this evening with us, is what closes wounds. It is really about thinking about that patient pathway and making it as short and practical for them and you as is possible, with as few complications as possible for that patient. Thank you for your time this evening, and I'm going to hand back to Alec, who will open the Q&A session.
Thank you, Jeanette, and thank you, Jacqui. That was very interesting. And thank you all for watching. I know there's hundreds of you at home tuning in and asking lots of questions. So we're going to get on to those. Before we do, we're just going to put a quick poll up onto the screen. So if you can just press yes or no for us. We are working on our program for the rest of the year, and with Smith+Nephew, and what we'd like to know is whether you find these events beneficial and whether you'd like to see more of them. So if you can click on the poll, which should be coming up on your screen now. And also, when you go onto the certificate download, the link will be up in just a moment. When you download your certificate, there's another question there where you'll be able to put in a bit more information in there. And do feel free to contact us and let us know of any specific content, any specific subject matters that you'd like us to present on and discuss. And so that said, without further ado, we'll go straight onto the questions, if that's all right with you, ladies. Okay, so the first question is, a lot of our wounds that aren't healing are leg ulcers. Can PICO be used under compression on leg ulcers? Jacqui, do you want to take that?
Yeah,
It seems like your sort of question.
Shall I start with that, Jeanette? That's okay. Yes, definitely. I think for those of you that can remember, even some years ago now, and certainly I remember supporting dressing changes for leg ulcers with or without compression that could be treated with traditional negative pressure, so the larger pump and the disposable canister system. Of course, with PICO now, things have moved on, so you're getting a smaller, more portable version that can help you not only with application, but it's not cumbersome to the patient and it doesn't impact their mobility, which I think is critical. If we look at some of the evidence, so there's a randomized controlled trial by Kirshner in 2019 who looked at venous leg ulcers and diabetic foot ulcers specifically, so the lower extremity wounds, and looked at the reductions in wound area, depth and volume using PICO versus traditional negative pressure over 12 weeks. And those reductions were really significant. I think just remember to ensure that the wound has low to moderate exudate levels and that the size of the wound is no more than 25% of the pad. So really following the instructions for use, and of course that none of the contraindications for use apply. I think it's also really important to have very clear achievable objectives for these wounds, ensuring that patient comorbidities are being managed effectively and that the gold standard treatment for VLUs has been followed. Jeanette, I know you were involved in a publication that looked at the use of PICO specifically with VLUs, if I remember rightly, with compression therapy. Is there anything you'd like to kind of add as our clinical expert tonight?
I think from my perspective, although the study that we wrote about wasn't necessarily a randomized control trial, it was more about the practical elements of managing venous leg ulcers with single-use negative pressure. And that in itself, it was really about making sure those things that you said, Jacqui, were addressed, so that patient is in the gold standard of treatment, that you know, you have optimized the compression, you've got the diagnosis right, and then perhaps if that isn't responding to that alone, but you're confident that that is right, then using something like single-use negative pressure to kickstart that healing. And sometimes, you know, especially if it's in a place where it's difficult to apply compression to, so the submalleolar ulcer and things like that, then I think you can get some really good results with single-use negative pressure. And the connection with PICO lends itself to being under compression, because it is going to maintain patent even under the compression, but not going to cause any pressure under that system as well. So yeah, absolutely can be used, and I've seen some dramatic results as a result of using it that way. Did you find application quite easy, Jeanette, then for particularly for absolutely VLU? even with hosiery? I think it's a skill, and I think, you know, it is also things that you need to think about is the skin integrity around it, because you still need to get a seal. But it's very much just a practical skill, and one that, you know, most caregivers operating in the NHS are very practical people, and it's something that is very easily taught and achieved for patients.
Can I just step in there and just say that we are talking specifically about PICO rather than negative pressure in general, because obviously there's other devices out there, and we don't want to be suggesting that people should go around sticking any using other negative pressure devices under compression unless they obviously check with that manufacturer first whether that's something. So this is very specifically about PICO. Okay, I think that's clear. Next question. Many of our hard to heal wounds aren't very wet. Isn't negative pressure wound therapy just for highly exuding wounds? Jeanette, do you want to take that one?
So I think both of those that I showed tonight are perhaps not wounds that you would necessarily always associate with negative pressure. I think some of the larger negative pressure, you know, portable devices now lend themselves to high exudative wounds with high volumes of exudate, but that is, it's almost like saying that is only one element of what negative pressure can do. It's very much about looking at the wound, looking at those signs and symptoms, making sure that it's within the boundaries of that manufacturer, as you said, Alec, and, you know, using it so you can manage the symptoms, but also the goal to treat that wound and reduce the amount of time that the patient has it, and act as quickly as possible in that journey to make sure that you're offsetting some of the complications, as I said earlier. So for me, I think it belittles what negative pressure can do if we only use it for highly exudating wounds.
Okay. The next question is a really interesting one, because it always seems to be a question that is asked of anybody trying to use negative pressure wound therapy. And this is, in our organization, we are restricted on our use of negative pressure or negative pressure wound therapy. Do you have any advice on how we could get wider use of this for better outcomes? And I think just to caveat that, I think a lot of the conversations I've had with Smith+Nephew about PICO and with other companies is simply that it's still seen as a specialist device. And I think that's specialist both from, you were touching on, Jeanette, about the cost the dress or the cost of the dressing, and not to think about the cost of the dressing or the treatment. Actually, it's the nurse time where the highest cost is. But because of the cost often associated with negative pressure, that's why it falls into that specialist category. But it also falls into a specialist category because it's not just a pad or a dressing or a garment.
So I think for me, Alec, it's about making it available at the point of care. I talked a lot about that. Mm-hmm. And for me, that's about trust. We need to trust our colleagues to do the right thing. We have had it available at the point of care now for the last 4 years within our organisation. We have seen a steady increase in its use, but we haven't seen an overall increase in the costs associated with wound care expenditure from a dressings perspective. But we have seen staff gain confidence, and we have seen staff able to use it to affect better outcomes and to reduce that, what I almost call the hangover of wounds, if you like. You know, if you're going in every day and you can go in once or twice a week, or the patient themselves can self-care with something like single-use negative pressure, then that releases time to care and it releases costs. I would go back to what I said. Think about what that change is that you want to make in practice, and challenge and steal ideas. You know, if those people want to contact me, and, you know, I can talk them through how I went about, you know, convincing our organisation to make that change in practice. And the data that we've got, we need to think a bit more smartly and steal with pride and collect data and do it in those incremental ways, so we can challenge the peers that this is what it means, and track costs across the system, because it is such a fractional cost. And I think we can't just hold it for a small amount of patients if we know that it's going to make an impact on a lot of patients' lives.
I think for me, Alec, sorry, just to add to what Jeanette said there, it's around understanding your service and really using something like a clinical audit tool to really have a look at the prevalence of wounds in your area, look at that associated burden. You can try and calculate what does that look like now, particularly for those patients that have had wounds for a long time. You know, the ongoing costs for patients, if we're just looking at it in terms of a health economy and trying to convince, if you like, purchasers or procurement that this is a good thing to do, then, you know, you need to be able to look at the bigger picture, if you like, and the longer term picture. I know certainly when I was in the NHS, it can be very reactive in terms of costs. So people that are less likely to look to, this is what we can save over the longer term. But actually, if you use really good, robust audit data that belongs to your service, that you can clearly demonstrate that, look, you know, we have a high percentage of wounds that really aren't healing, and there is an opportunity here, not for all of those wounds, but for a percentage of them, to use, and, you know, something that's innovative technology, a little bit outside the box, then we can not only reduce costs, we can make the patient experience so much better, which is obviously what it's all about, but that we can release time, as Jeanette said, as clinicians, to do more with that time. So it's a kind of understanding your service as well, I think, really, so that you know which direction to take it in. Do you agree, Jeanette, that's a, you know?
Yeah, and I think there are several kind of adjunctive ways of kickstarting that audit as well, and, you know, lots of more interactive ways than sending out, you know, just paper-based systems where you can get that data quite quickly back and analysed for you, so you're able to act.
Okay. Jacqui, I think this probably is best going to you. It's very specific, this question. It's what's the maximum depth of wounds that you can use negative pressure wound therapy on?
Okay, so we try not to give a maximum where possible, Alec. And the reason that we don't is that when we very first started with PICO, it was very much around sort of, you know, the 2 centimetre mark. But as clinical practice has developed and clinicians have started to use pico outside the norm, if you like, on a variety of wounds, we've seen that there's more evidence that has been available in terms of the depth of the wound. So certainly Teresa Hurd has got some evidence to suggest around 4.5 centimetres is absolutely fine with pico. But as I said, don't kind of hold on to that depth too much. There will be more evidence coming as we start to look at deeper wounds in clinical practice. But certainly we try not to give a maximum at this time, like I say, because that evidence is constantly evolving.
Okay, I think that's I think that answers that question. Next question. I think we touched on it earlier when we were talking about sort of opening the making negative pressure available on a sort of a wider scale. But the next question is, in our practice, only tissue viability nurses can use negative pressure wound therapy. Can you advise? I think we've probably touched on that with in answer to the last question. So we'll come back.
Ask them why, Alec. That's what I would say. Ask them why.
Yeah, I think that's probably the best advice, isn't it?
And there is a way of asking that, but challenge that.
The next one's an interesting question. What is the best advice for areas with hair, as well as difficult to dress places? Who wants to tackle that?
I guess, yeah, go on, Jeanette.
There you go. Jeanette, do you want to go first? Yeah.
From a patient perspective, you don't want to be waxing somebody when you take the dressing off. And I think it's really important to get a good seal. So if somebody is very hirsute, I would advocate removing that hair, just by simple shaving and monitoring the area for things like folliculitis and things afterwards. But definitely, prepare that area around where your seal is going to be and do that in such a way that it is sustainable, because the patient's going to run into more problems with the seal, and that can also lead to the patient becoming disillusioned with therapy as well.
Okay, I'm going to move on to the next question because this is we're running out of time, and this next question is another one that is quite interesting here. This is can negative pressure wound therapy be used on incision and drainage abscess wounds? Do you want to take that, Jacqui, as the final question?
Yeah, so definitely we use it a lot in incision. The ability for pico to really bolster an incision post-surgery has been proven, and obviously there's a nice directive around that as to how that should be used clinically. I think, as with anything, it's about appropriate use, it's about appropriate application. I think, did you say something about drainage? We wouldn't use pico outside of the instructions for use and its intended usage. So it would be to bolster that incision line rather than get involved in any drainage.
It was on can be used on incision and drainage abscess wounds.
I think as long as it's been surgically incised and drained, then absolutely you could. It was say a pilonidal sinus and you could get a seal on that area, as long as you were, it wasn't being used to address the abscess and the abscess had been addressed surgically.
Okay. Okay, so I think that brings us to the end of the presentation. Thank you very much, both. For those of you that have asked questions that we haven't got back, that we haven't answered today, the presentation will be available on our website from tomorrow, and you'll be able to rewatch this presentation via our Facebook page immediately after we log off, should you wish to watch it again or share it with any of your colleagues over the next few days. Thank you very much for taking part. Obviously, getting the questions in and seeing your comments is a really important part of these virtual events. Smith+Nephew will provide you or can provide you with any of the information around the evidence that is being discussed this evening. You can basically either visit their website, which is smith-nephew.com/pico. That should be on your screen now. Or you can actually email them, which is askaboutpico@smith-nephew.com. It's sometimes difficult for you to take all this information down as we finish. So when you go to the certificate link, which is available, which should be available on your screen now to download, there is an option on there for you to say that you'd like your information shared, and then we can pass that on to Smith+Nephew, who can contact you to find out what further information you would like. So then if you want, they can contact you to maybe come and demonstrate the product, or to share with you the evidence, or to talk to you about other events in the future that potentially you'd like to join us to watch. So please do that. Thank you very much for joining us. To all of my team and to Smith+Nephew, I'd just like to thank you again for supporting this. But most importantly to Jacqui and Jeanette, because this isn't easy, sitting in front of your computer, looking at me while talking. I'm very, very aware of that. So well done both. Thank you very much, everybody. Good night, and we look forward to seeing you all again soon. Goodbye.